What's the diagnosis? You don't see the injury.
A carpal bone fracture.
Alright, so
Hold on.
let's see the
Don't take
history.
it down yet.
So this is a 45-year-old lady who fell on her outstretched hand, and she comes with pain in her wrist.
It's a Achilles fracture.
So far.
So she has a Colles fracture, right? So she has a Colles fracture. Everybody know what a Colles fracture is, right?
Yes.
I hear one voice.
Yes, sir.
Yes, sir.
Alright, so we know what a Colles fracture is. You can see again, remember, what is this? Give me some of the features of it.
Did it fall deformity?
Did a form deformity, right? But I mean, want to tell me about the characteristics?
Oh,
Look at the fracture again. You see, don't look at it. Like, look and see. I mean, look and see how the bone is. Where's the hand? The hand has gone backwards or forward? Here's the palm of the hand. Here's the back of the hand. Look at the fracture. Look at this here. Now, I mean, you see the example will start with you looking at the X-ray. You don't see any cast there, right?
No.
So that's the X-ray you're gonna get first. Yeah. Once you get that okay, you're doing well, then you might go to that one. Right? So let's look at this one first. Look over there. So again, when you see this, if you're given this X-ray, let me hear the sharpshooter that are going to say what they want.
Lateral and
So I mean, but don't say.
don't say it. Okay.
What Anthony, what do you see? You see again when you say that. What are you looking at here? Which view are you looking at here?
Lateral.
Right. So why you say why you need the lateral thing? You see, tell the examiner I need the AP.
Okay.
Right. Okay, you see why I can stop you. That's what you're looking at here. Yeah. You see the lateral, so you want the AP to get a full appreciation of what you look at. Right. So you can see. I mean, so you know again. You remember I said how you talk about Colles fracture. Who does it occur commonly in again? Remember, for you, it's the most common thing. It most commonly occur in what's the F words we use? Female, fat, fertile, 40. Plus 40, whatever. Yeah. And then, but you also, again, you fall in the outstretched hand. So again, where you think your hand is going to go? Look and see where you fall in your hand. Your hand is going to go forward. Where you fall in, how where your hand is going to go? Backwards, right? Backward, look at it. Has it gone backward? Yeah, look and see. Remember, this is, here is the fracture. Here's the, remember again, the proximal bit is the intact thing. Look and see where your hand should be. So you see it's going backwards? But that's where it should be. But look and see how it's, you see how it's tilted over there? Or if you want to say angulated, there. Agree? You see that or you don't see that?
I see that. No, your finger.
You don't see
You
that?
could do it from the neck. I don't know.
Huh? Again. Yeah,
No,
so-
I mean, I just couldn't see it from where I'm standing.
Huh? Well, why don't you come and stay in this direction so you can see?
Yeah.
Yeah. So,
Yeah, you can do it.
yeah, so let's again, here's the proximal fragment, the end of the proximal fragment. See the cortex ends there? Agree? And in fact, I will tell you now, this, as I said to you before, if you look and see how you see the cortex of the radius is going there. You see how you don't see the cortex of the fracture? Agree? That's the one of the cortices of the proximal fragment. Agree? You see that?
Yes.
You see how you don't see it down there?
Right.
What it tells you right away, what it tells us, I taught you all that principle as well. Where you see that you can't see what it tells you right away. There's rotation. There's rotation in fracture, right? Remember I said again, you always get a rotatory injury in this fracture as well, because you say you can't see it because now the fragment has rotated. That's why you're not seeing the orientation. In fact, let's look at. In fact, look at this now. You see how it looks. You can see how it comes back there now. You see, you see that. You see how you can see the fragment, the cortex there now. But I mean, you can see it's not fully reduced here either. But at least it's attempting to. But maybe look at a good reduction. You should see that. But the fracture, remember I said again, it gets posteriorly shifted and tilted, laterally shifted and tilted. You see what's over there? Laterally the thumb, laterally shifted and tilted. Impaction. You see how it's going into the fracture where you do that in fracture with that jam into each other. Yeah?
You can show where it's posteriorly
Alright. So this is the anterior, right? You agree with that? That's the palm of the hand.
Yes.
This is the back of the hand.
Yes.
Alright.
It's tilted towards
So,
the posterior.
remember we differentiated tilt and thing for you. Bring the marker for me so we can show it.
So tilted would be posteriorly, but if we use angulated, we'll
It'll
say
be
anteriorly.
Yeah,
Okay.
yeah, because you can see the angle is being formed.
Direction.
Yeah. You remember something. See
Thank you. Alright, so again guys, you see again you have to listen, you have to
It's right.
The red.
Oh, you have an next one?
something like that.
All them, most of them were like that.
Yeah, I thought so. There's two more here. Talked about it. We could try these.
You got one more.
There you go. So let's do a perfect reduction. Yeah, so yeah, great. You see that?
Yes.
So you see how you will see the cortex over there if it's in the same plane of alignment, you will see the cortex over there, like how you're not seeing the cortex over here. Agree? So you know right away if you're seeing the fracture with what the bone that is normal in not the same sort of anatomical alignment, it tells you right away there had to be some rotatory deformity. Right? So this is the well, I mean, I put a fraction here, but that's obviously where you reduce the fraction, you want to go back to what was normal. So that's equivalent to normal. Remember again, here's anterior, I'm doing it exactly as I see here, and here's posterior, right? Right. So what happens in fraction? When you fall and you break, then it's going to, the fragment is going to be pushed backwards. Okay, this one is losing its touch too. Let's see this one there, this one there. Yeah. So in addition, as I said, we say posterior shift and tilt. Shift is a linear thing. So you agree that it's going backwards, right?
Yes.
It's here, yeah? So it's going to be, is in addition to a linear displacement, you're also going to get an angle. Look at the angle. Look at the axis of the fraction. You see where it's formed that angle?
Oh, okay.
So as Ianthea correctly said there just now, remember you can either look and see where the axis, the apex of the angle is. The apex of the angle is either anteriorly, or you can say it's tilt, because remember, tilt is equal and opposite to angulation. But why we say use tilt? Because how you're going to correct that? You have to correct it by bringing it anteriorly.
Anteriorly,
Whereas if you see, we just said you have to bring the fracture anteriorly. Remember, say when you use angulation, you have to go in the same direction, and that doesn't click well with a young doctor. Because if it's anteriorly angulated, well, you would say to yourself, well, I need a posteriorly angulated. You see what you're saying there?
Yeah,
so
that's
you see,
true.
But again, there's nothing wrong with using angulation. If I say that I still need to bring the fracture anteriorly. That's why you need to say
Okay.
tell yourself if you're going. But it doesn't matter if you're going to use whichever one you use. Just understand the principle. So you see that? You see how it's tilted posteriorly?
Yes.
But it's gone from here to there, over there, right? So it's gone. So in addition to laterally, posteriorly shifted in a linear plane. In fact, let's look at this one is showing the lateral because it's posterior and laterally shifted and tilt, right? So look at this one here now. Look and see how it's see how it's laterally going, laterally shifted
Yes.
over the thumb again, thumb side. So it's lateral. You see the refraction's gone over? Lateral. So it's the same principle of it has gone posteriorly. This one is not showing you it clearly. But again, remember when you look at a fraction, every fraction is not going to show you all of the principles of that fraction. But I mean, you're being tested, so you have to know what is the perfect fraction, right? Well, I don't know it's a perfect fraction, but if you get what I'm trying to say, you have to be able to talk about what are the characteristics of a Gauss fraction. But every patient that walks through the door is not going to have any. Right? But again, you see, so you see this, you see a lateral shift there. You can see that, right?
Yeah.
So that's the same principle you're going to see in the posterior. It will be, so let's make it look perfect now. So there's going to be some posteriorly shift over there. Agree? You see that? Linear
Yes.
plane. But remember, it doesn't go in one plane, but also they also have this angular thing we talk about as well too. And you can see that, right? Because if you draw here, you see how the fracture, where the fracture, it should be here, right? So you see right away it's gone. You see how it's formed an angle?
Yeah.
It's gone over here, so it's formed an angle. So that's the tilt. Because I need to correct that, I need to bring that forward. You see that? Likewise, if a shift, I need to bring that back over here as well too. So again, as I said, the way how to say it is that yes, there's a falling outstretched hand, you know, the nerve's common fracture within the 3 centimeters of the wrist joint. Yeah, it shows lateral and posterior shift, lateral and posterior tilt, or if you want to say anterior. There you go, right? Remember, I don't use it because I kind of try to make it simple. But also to look and see where the fraction, there's some impaction, because you think about it, when you break, that proximal fragment is going to jam into the distal fragment. So here we say 5 things there just now. Posterior and lateral tilt and shift, 4. Impaction. But also too, you just heard me say there's a rotatory component as well too, because when you're falling down, what happens? You're falling down, you try to stop yourself. So what happens? You're trying to falling down, but you're trying to bring yourself back up. You see what happens? You see how you end up with rotatory deformity. And there is a 7th thing that I said happens sometimes with the ulnar styloid. Let's see if you can see it here. Yeah, you don't see it. Look at this one here now. This is a better reduction here now, but sometimes you see the ulnar styloid comes off with the fracture. Yeah, remember I said that's one of the areas that doesn't heal normally, when you get commonly get non-union.
Yes.
The ulnar styloid sometimes can come off as well. Right? So you can see how you see there's still some lateral shift here. It's not perfect. Yeah. And you can see also, look and see the cortex now. You see how the cortex again is not perfect. So you know it's not perfectly rotated around. Yeah? But you can see the proximal fragments there, still there. Alright. So, as I said, that is the way how you would describe it. But then you go on and then, because you described it, you know what the treatment should be, because you need to reverse all of those forces that have been abnormal forces. But look and see the person has reversed it and put it in a cast. You see that?
Yeah.
But what they haven't done. What are the 3 R's again for treatment? So I've told you now. Remember, every treatment, everything in the orthopedics is the 3 R's. What was the 3 R's? Reduce,
Restrain and rehabilitate.
There you go. So you see how the person haven't done the first one, and you have to do it in a sequential way. They have not done the first R. But they haven't in the past. So guys, this is what I'm saying to you now. Remember just what it is. Say I keep telling you guys. I keep telling you what I tell you in this room is the same thing again. Ask the example. So you can see how you're going to ask this first, and if you're doing all right, people can take you. Well, what is wrong about this here? So they're going to get to ask you about the 3 R's? Yeah. So you know that is wrong because you would say the person hasn't done the first one. They haven't reduced it. Because it looks the same like that, right? They just put the patient in the plaster. They haven't done the reduction.
That's crazy.
Yeah. Well, you see it right. I didn't make it up. It's right in front of you there. I mean, this person has made a good attempt. This would be acceptable, really, because you know you can get remodel it. So you see, if you go on this now, you say this is acceptable. It's in the plaster, the splint. It's acceptable because we know, although it's not perfect, we know it will be modeled by whose law? Wolff's law, right? Wolff, W-O-U-L-F-F, right? There you go. Right.
So how did you see the ulnar styloid come off? It's because of this cortex?
Well, if you see, obviously that on the styloid will be pulled away, but again, I know you obviously haven't read it in your book to show the principle, because why it comes away, because yeah, the triangular cartilage attaches onto the medial side of the radius. Yeah, the medial fossa there, it attaches there, and attaches onto the base of the ulnar styloid. Yeah, it's a triangular fiber cartilage that extends from there to there. So you look and see what happens what happens to the fracture? The fracture goes where? Over here, right? Agree? And it goes backwards. So what do you think happens to that cartilage? It comes with it. It comes with it. Is it? So it pulls away from the ulnar styloid. But you see again how the ligament is stronger than the bone. It literally you will break your bone before you rupture your ligament. So it breaks the ulnar styloid. So again, when you look at your book, you will see the cartilage is attached it stays attached to the radius, and it breaks the ulnar styloid. Okay? And since that is cortical bone, what happens? It doesn't heal. So you develop a non-union. You get it?
Yeah.
Yeah. Now, the other thing that we need to mention, again, I don't have to tell you, you have to reverse all those forces, but I told you about the principle of where you put the plaster again, because that's another MCQ question, how you put the splint, where you put the splint again. Guys, again, you see, again, that's what I'm saying. I would Miss Shantae today, she was going to get my logic to her. But you see, if you think about it, guys, the fracture, I suppose that's where you have to bring in your chemistry and biochemistry. But if the fracture has displaced laterally and posteriorly, from what we said, you want to correct it by pushing it what? Anteriorly and medially. So where you think you'll put your split to keep it there?
Medially and anteriorly.
No, guys, you will push it back to where it came from. You want to keep it. So if it is come laterally and posteriorly, so you want to correct by pushing it medially and pushing it anteriorly. So the cast have to come over here to keep it in that position. So you want to put something posteriorly to stop it going back, because that's the stable point. You want to stop it going back posteriorly. You want to stop it going back laterally. So you see, you have to put the plaster, that part of this thing, you can't put it circumferentially. So you want, because why you don't put it circumferentially? You know it's going to swell. You don't want to cut off the patient's circulation, right? So you put the splint is on the lateral posterior aspect of the limb.
Oh, just to stop it from going laterally and posteriorly, okay.
Because that's the stable point. See how energy and biochemistry comes in? That's the stable part of the fracture. You're putting it back to normal, which is the unstable bit. So to keep it in that position, that's what the cast does. The cast keeps it from coming back, going to where it's right. You see? So the plaster has to be on the lateral posterior aspect of the thing. I mean, we put it as, so it really should be a U. So see how the U stops it? Yeah? So the medial bit is the bit that's exposed. Agree?
Yeah.
Also too, you remember I said, you don't include,
The finger.
no, you don't include the knuckles. You leave those MCP joints free so the patient can start the third R immediately. I saw a patient this week, again, you see how, I hope you all don't get into that thing, but the patient was sent to, had a fracture, well, she had a fracture, but the doctor would say she had a fracture. Put the patient in the cast, and he had her on for 4 weeks, and he didn't, I asked her specifically, did the doctor tell you about moving your limb in this? No. Of course, you know what she turned up with? She turned up with a DVT in her leg. Yeah?
Wow.
You see, because I'm telling you, guys, I'm telling you, remember, it's going to be you there dealing with the patient. It's your duty to tell the patient. Remember, because what the patient come with that broken leg, what are they going to do? No, I can't move this. That's the first thing they say. But you the one who have to tell, they still have to move that. In fact, that's exactly, oh, I can't move that. I said, no, ma'am. And I used my hand to show her the plaster that she came with. I said, look and see what I'm doing. You see, my hand in the plaster, but I can still do my exercise. So that's what you're supposed to tell the patient. So don't forget that third R. I'm telling you, that's what doctors forget all the time. Okay, so you put the plaster in to stop the fracture going back to its stable position. Remember, the fracture is a stable position. That's why it stayed that way. Right? That's a stable position. Enthalpy from chemistry. So you want to put it back there, and if you don't think about it, if you don't put the plaster on, what do you think will happen? It's gonna go right back to where it came from, right? So you want to stop it. So how you stop that? You put the plaster on the lateral and posterior aspect to stop it going back there. Also leave the knuckles, the empty, so the patient can move the limbs. And that is different, as I said, you always differentiate because that's how the MCQ question you see. Because remember now, when the patient has a scaphoid fracture, you include the MCP joint of the thumb. See the difference? That's what the MCQ asks you. Yeah? So you don't include it in the Colles. Obviously, you don't include it in the scaphoid either, but you It is in those four, but with the thumb, you include the MCP joint for the scaphoid fracture.
Okay.
Right? So if you have this type of thing, you get the point of where they ask you, so tell me some of the complications, tell me 2 or 3 complications that can happen with that fracture. The Colles fracture. What are you concerned about the Colles fracture?
The Dennefolk deformity.
Well, that's the deformity the patient's going to come with. That's the, and in fact, you mentioned that. That is exactly what sometimes you see XCQ question says that. It doesn't tell you the patient have a Colles fracture, right? The patient comes with the deformity. You see how you have to know that equals Colles fracture, right? So just remember that. Yeah? So that's what the patient comes with. That's not the complication. What's the complication the patient can come with?
Vascular compromise.
Okay. That is not common in this type of injury.
Okay.
Remember again, remember I said at your level, try to speak what is common in this patient. There you go, remember again, you see, as I said again, guys, let's go back again to the principles. When people ask you that, don't think I can't answer a question. As I said, think about the structures that are in the region that you're talking about. You either can start superficial and go deep, or start bone and go up. So you see how you'll be able to answer it. So someone, you just said it, non-union or malunion. But remember we said, what type of bone is this? This is cancellous bone. Does cancellous bones non-unite? So you remember we said that that's another thing. Again, see how you can differentiate the goats from the sheep? Again, you hardly see non-union in a Colles fracture. But what do you get? Think about that one. What happened there? The patient get malunion, right? Because the doctor did reduce it. So malunion is common. Non-union is seen. Remember, hear what I said? Almost never seen. But you don't say non-union never occurs. So you see the difference? Don't say that. Because, yeah, it can happen. Guys. We know non-union. If the patient got a tumor there or infection, it will non-unite, right? So, but the common thing is a malunion. That's can happen. A malunion because the doctor haven't reduced it properly. All right. I remember I said 2 or 3 complications. So going to be. So remember I said again, when you think about it, think about what you told me something happened to the bone. What are the structures around that area? What are the other common structures around that? What are the other things that can happen to these things that move your fingers? Remember? You see the radial nerves, and you know things that happen, but you see again, I said try to treat the common things.
Tendons.
Yeah. Well, there's one common tendon that gets commonly associated with the Colles fracture. You see how you guys, it's all on your lectures. I've been through them several times. Remember I said to you that the patient comes back and they can't extend their thumb. What extends your thumb? What's the thumb called? What's the Latin for the thumb?
Brevis.
Extensor pollicis longus. There's a rupture of the extensor pollicis longus. That's the common associated tendon injury with the Colles fracture, because the tendon has its very tortuous course. Remember again, that's what it was. Yeah? Look and see where that tendon, that's the groove formed by that tendon. You see where it has to come from? So the extensor pollicis longus comes way over on the medial side of the forearm, and then it has to, look at the course it has to take to get over there. It's not a tendon that coming straight to the thumb. So you see how guys, I showed you all these when I was teaching you. Yeah. So it comes because of that. So again, think about, you see why that happens. And remember again now, what happens to the fracture? It goes backwards. So you see, even put more tension on that tendon. You see that? So the patient, that's the fact that the patient might not even come with it right away, but because of think about it. If I push something backward, look and see what's going to happen to the blood supply, that tendon. You see it puts tension on it, and it becomes relatively ischemic, and the tendon eventually pops. So because of because remember this fragment now is going backwards, so it's going to take the tendon also backwards, and it's under a lot of pressure. So you get the tendon's rupture, but that's the one because of its tortuous course and long course that gets ruptured. So how the patient comes? The patient comes unable to extend their thumb. Again, look back at the lecture. There's a picture that I showed you in the lecture. The patient can extend their thumb. Extensor pollicis longus rupture. The other thing they can get as well too. I mean, You don't commonly see generalized nerve lesions like a radial nerve, but you can get what can happen to the median nerve? You can get a what's the common lesion of the median nerve at the wrist? Common nerve at the wrist, median nerve. That what injury, what condition we associate with the median? Carpal tunnel syndrome. You can get an acute carpal tunnel syndrome. Yeah. Or there's another complex thing you get when you get injuries around the wrist as well. What we call that again? Complex regional pain syndrome, pseudex atrophy, algodystrophy. Remember again, it's all there. As I said, I know everybody don't come to lectures every Saturday, but I know I've taught you them. So I mean, as you said, if you haven't grasped it, you need to grasp it because there's certain things I always mention that the things that applies to all fractures. That's one of the things. I hope we talk about compartment syndrome, complex regional pain syndrome, infections. You see, those things can happen every fracture. I've spent a day talking about all of those things. So, yeah. So, but those are the common things that occur with that. That's part of injury. All right. Larry, as I said to you before,